All right, Dogg from Air Fans. Evan Benton back in the saddle here with another COVID update. So the situation is I've been back at work for a couple months, and what I do for work is I am a massage therapist, and I don't think it's common knowledge. So I want to start by saying that when you're in a massage session, people talk. It's like it's like going to the barber. As much as possible for me because it's more interesting to have people talk. And most of my clients are nurses or doctors here in New Orleans. So I hear a lot of crazy stuff. And of course, I've been plugging them, pumping them for information uh, every chance I can get. I'm not going to name any names in this video. I'm not going to name any hospitals because I don't want to get anyone in trouble. So this is all going to be unqualified information. Take it or leave it. Believe me or don't. Okay. So first of all, of course, pretty much all of my clients are telling me that the hospitals are fine. They were never. They said it was like a war zone at the very beginning, but they were never at risk of being overrun. They are now fine. There's plenty of space available in the hospitals, so all that is just garbage according to my clients. But I got a few juicy tidbits I want to share. Okay, so the first one, a doctor at a certain hospital somewhere told me that doctors and nurses were reusing inhalers, and they were reusing nebulizers between COVID cases, between COVID cases and possibly non-COVID cases. This doctor saw that this was happening and she put the stop on it, but it was apparently ordered by the chief pharmacist or whatever that position is called. So it was a policy decision that was made by the head of the pharmacy department at this certain hospital. And I asked the doctor, so you were spreading COVID? And she said, yes, we were spreading COVID. And so she actually believed that she caught COVID from one of these nebulizers that were being used on an infected patient. So what a nebulizer is it's a device that takes a medication and it turns it into like a gas so that it can be more easily absorbed into the patient's lungs. And it's not a closed system, so it doesn't just blow air into the lungs. It also takes air that's in the lungs and puts them out into the room, so it can infect if there's anything infectious in that person's lungs that goes out into the room. You can see the problem there. Of course, a lot of doctors were reporting that they were told to reuse the PPE, the personal protective equipment. That includes gowns and masks. I think that was reported a lot in the news as well. But what they told me that you might not have heard is that this had never happened in their whole careers, and that they had plenty of PPE. It was just they were told not to use it or to reuse it from patient to patient. Going against the protocol in general. So you might argue that they're doing this because they're worried about a huge upsurge in patients and they have to conserve them. But if they're potentially spreading a disease by that decision, then what sense does that make? It makes absolutely no sense. So, and then on the other hand, I don't think it's been reported that a lot of hospitals are making $100 million infrastructure improvements right now, building new wings, making investments in equipment that they might need. So they're not able to buy masks for the first responders, as we're calling them now, but they can make all these $1 million infrastructure improvements. That makes absolutely no sense. Pure graft right there. So next little thing, I can say the name of this hospital because I've verified it independently. There was a power outage at one of the COVID wings at Oshner main campus in the New Orleans area. It was caused by an electrical fire. So my first thought is sabotage. Sabotage why? That's the question. So first of all, yes, people on ventilators, the ventilators lost power. It was reported to me that people were, nurses, etc., were handbagging the patients. That means they're squeezing these bags that are putting air into the lungs manually, and they were out of power for an hour at least. One nurse described it as a nightmare scenario, but apparently nobody died. During that hour at least, I'd be interested to hear if that contributed to any deaths down the road among those recovering patients. I'm sure that'll never be reported. But my first thought was it was somewhere in Central or Eastern Europe where there was an attack on the hospital that was holding all of the COVID testing data, and all that data was stolen. And while I was trying to find that link, I found just so many other cases of COVID data, specifically hackings, that I decided to talk about those instead of that other thing. So in Nicaragua, this just happened a few days ago. The entire patient database was broken into and stolen. And the mainstream media is actually reporting this as a good thing. They're saying it was the hacking group Anonymous that did this, and they're like telling us the truth because Nicaragua is one of these terrible terrorist regimes that's not telling us how dastardly the COVID is. And thank goodness we have these anonymous whistleblowers. That's the spin that's being put on there. Indonesia, 230,000 patients had their data stolen. And again, specifically, it's the COVID status, positive or negative, of the patients that these hackers are looking for whatever reason. And then finally, there's this story from USA Today. The headline is "A Game of Cat and Mouse. Hacking attacks on hospitals for patient data increase during coronavirus pandemic." I'm just going to go through the numbers here, okay? From an IBM researchers, they reported a 60,000% increase in spam attacks on American hospitals between March and April. 60,000%, that's a 60-fold increase in just 2 months. A study or a survey from January earlier this year found that 83% of American medical practices had been the victims of cyber attacks. And then also back to IBM and recent months, whatever that means, they said that the USA had a 75% increase in security events. And for for Europe and the Middle East, it was 125% increase in security events. So I'm assuming that means an actual successful hack. And then there's this, they're also reporting Russia is trying to steal vaccine data and China is trying to steal vaccine data for the COVID vaccine. So, I mean, that's just silly. But with this other stuff, they're stealing patient data, okay, and specifically the COVID status of the patients. And so, therefore, just that fact alone tells us that there is not a shred of credibility to any of this testing information. The fact that the test itself is not designed to diagnose pathogens, notwithstanding the presence of pathogens, that's another story. But this is another point that just shows us that the data is all, I don't know what F word to use, okay, but it's not real. There's no story here, for whatever reason, okay. Another really interesting point that really made me think and made me think, this is real for a second. One of my nurse clients told me that the initial wave here in New Orleans consisted of 95% African American males. And then the second wave consisted of 95% Hispanic males. And I really perked up at this because it's a pattern, and it's really about the first pattern that I've seen in the entire, reporting of this crazy event. Okay, um, and so the pattern, of course, that's a statistical category, race, and I just want to say that people can play around with statistics a lot, and something about statistical categories is that this race category might be obscuring a more um, relevant statistical category, such as place of employment, place of residence, maybe certain risk factors that members of that race and gender might have in common. You can think about what those might be, but I'm just going to go on to something else that they mentioned, which is the couple people call this the trifecta, the COVID trifecta. Okay, if a patient has obesity, heart disease, and diabetes, okay, they're gonna have COVID. That's what they see. So those are associated with certain demographic groups, but they're also associated with poor health in general. So it's like, you know, we all know that, right? We all know that they're now reporting, the CDC is now reporting a mere 6% of the excess mortality of 180,000 is linked to COVID. So that's what we're talking about. We're talking about 9,000 people, which is a small. I don't want to do the math right now, but it's a small part of the United States, right, to be shutting down the entire country. Okay, so, and then I think this is my final point here, and this is the real thing that makes you go, huh. I spoke to a woman who trains respiratory therapists. Okay, that's her job, is to turn out the next batch of respiratory therapists. Respiratory therapists, among other things, work the ventilators that you hear about. Okay, she told me, yes, ventilators killed people. Yes, ventilators killed people. I had that omission from someone who teaches people how to use them. Okay, she said that they found out through basically trial and error, emphasis on error, that ventilators were not appropriate for this pandemic. But the other options, which they did have, they were told not to use them because of the risk of spreading the disease, like with the nebulizer I mentioned. So a ventilator is a closed system. It just keeps everything inside the person's respiratory system. So well, anyway, to a greater degree, I understand than like a nebulizer or something. So, but then here's another really crazy point that she told me that I had no idea of. And she said that in some hospitals, it's the doctors who run the ventilators, and in some hospitals, it's the respiratory therapists who run the hospitals. Sorry, the respiratory therapists who run the ventilators. So think about that: a doctor who's got about 8 years of schooling versus a respiratory therapist who's got about 2 years of schooling. You don't think there's going to be a difference in patient outcome there? Like, give me a break, okay? And yeah, just again, that's a policy distinction, okay? This is not physicians who are making these choices. These are administrators, and that's the point you got to think about. I don't think that a lot of people understand, and I wouldn't if I weren't talking to these people every day. Is that so much of patient outcome is determined at the policy level by administrators and not by physicians. And I mean, look at what the education requirements for an epidemiologist is. Epidemiology, it's not an epidemiology degree, it's a hospital administration degree. So, think about that. The emphasis is on, I guess, moving drugs around and moving supplies around the supply chain. And at any rate, that's what has failed. We ran out of PPE supposedly. So the way that it's designed to work, just failed. And that's what they're doing when they do these things like Operation Ox last year in Oregon, et cetera, when they're preparing for these kinds of things, right? Operation Ox was a bubonic plague, practice outbreak. And now we know what that was a trial run for. But anyway, so it just gives you an idea of how we can have a disparate outcome from one hospital to the next. And by the way, another question I asked a lot of these doctors and nurses is your hospital using hydroxychloroquine? Some of them are, some of them aren't in the same city. Okay, but that's, I can tell you which hospital to go to at least a couple months ago when I started talking to them about this in New Orleans. But it changes. Like, that's another thing they told me, is it changes every day. They're updating the policy for whatever reason, based on whatever set of information that we're not privy to. Okay. So just an idea, some people are like, there's no way this could be a fraud. Well, I'm detailing to you how this could be a fraud. All right. So, and this brings up one possibility that came to mind. There's theoretically, could you design a pathogen to just drive the patient's oxygen saturation level below a certain point, which is a little dial on the ventilator, and then the ventilator just takes care of the rest. Okay, so the operator sees that number and then just says, oh, we got to keep adjusting. Oh, we just got adjusting. And then the patient's lungs, rupture from all the excess air going into them. I don't know. That seems pretty far-fetched to me. But, that's something I thought about, is that, just the effect of the thing is supposedly affecting everyone. Could it be just to alter the reading on an instrument, which then forces the care provider into a certain, set of choices that then kill the patient? It's a far-fetched yet disturbing possibility. I think it's a lot more. I think it's a lot more straightforward. It's convoluted, but it's not. We're not dealing with some sort of novel virus here. Okay. So, but there's a new theory that was put out after a supercomputer at the Oak Ridge National Laboratory, which I believe was created for the Manhattan Project, crunched the numbers on the coronavirus for a whole week, and they found basically what we already knew, but they found that the supposed virus infects our cells by targeting the ACE2 receptors. Okay, so, and it's just, I guess it's a little variation on this thing they're reporting, way back in March, etc. That and like smoking upregulates the production of ACE2 receptors. Okay, but something else that affects the ACE2 receptors are a drug class called ACE inhibitors. And these are basically things that drive a patient's blood pressure down. Okay, blood pressure medication affects the ACE2 receptors and has a lot of these crazy symptoms like loss of taste, loss of smell, the lungs filling up with fluid. Look it up. And gee golly, are a lot of these patients having, are a lot of these patients on the blood pressure medication? Yeah, they certainly are. Another crazy thing that connects into here is that 35% of professional athletes were reported recently to be 35% of professional athletes who tested positive for the coronavirus are also diagnosed with myocarditis. So that's an inflammation of the heart muscle, which is another condition that's treated with blood pressure medication. Okay, so that's another link there. So, so these different things in combination, blood pressure medication combined with a poor diet, combined with obesity, combined with heart disease, combined with diabetes, and all those medications that you're taking for all those different diseases, plus being on a ventilator that you shouldn't be on in the first place, plus whatever medication you're on for whatever they're trying for COVID, besides the things that we know work, like hydroxychloroquine, and whatever else seem to work, the zinc and the vitamin C. And I mean, I just don't think there's any story here at all. Okay. Another thing, think about this. Okay, age, right? Another something that influences people, influences morbidity with coronavirus. Well, the baby boom, 1945 to 1964. All right, statistically, a statistical increase in births. What is going to follow a statistical increase in births? You guessed it, a statistical increase in deaths, okay? And 1945 was 75 years ago this year. And what's the average life expectancy of a human being? Okay? So we're just at the time when baby boomers are bound to start dropping like flies, okay? And they have these conditions, okay? So, there you go. That's just something to think about, okay? So, but the good thing about all this is that we know these people have played their hands, okay? I, for one, if you've watched any of my earlier videos, I was real worried about a bioweapon, and now we know they don't have one, okay? Or at least they don't have, I mean, there are bioweapons, of course, but they don't have this bioweapon that's going to wipe everyone out, okay? It just doesn't exist. If it did, they would have used it, all right? So we know that we don't have to worry about that, and that's great, and we can all open up and stop wearing our masks and all these silly things. But so that's that. That's my retelling of all of my fascinating anecdotes from talking to people in the healthcare industry here, talking to first responders. So I want to go on to now just what the real bioweapons scenario looks like, in my opinion, from studying this for a long time, from having a wife who has been fighting Lyme disease for over 20 years, which is a bioweapon, okay? So there are sleeper cells, okay? There's groups of individuals who are secretly employed by some intelligence agency, okay? They have a safe house where they can hang low if they need to, or meet, or, have new agents come and join them. The safe house has a freezer. The back of the freezer, there's a little vial in a plastic bag or a paper bag with some instructions on it. The instructions might say, take this vial and dump it in an air conditioner system. Take this one, dump it in a hot water heater. Take this one, pour it in a drinking fountain. Take this one, put it in a public pool. Take this one and go and smear it on doorknobs. Take this one and smear it on a tree at a dog park. Another one is a little Binaca bottle, if you remember those. Can fit in the palm of your hands, and as you're walking by the produce section at the grocery store, you just give all the avocados a little spray. Maybe you just give all the salad bar spray there, okay? And they're all different diseases, but they all produce respiratory symptoms, okay? And you put those together, can you add up to 180,000 deaths? Well, when 90% of those deaths are also having all these pre-existing conditions that are bound to kill you anyway, when 40% of those deaths are happening in retirement homes, where they've got the closed system with the air conditioner that can get infected with Legionnaires and other things, in the closed water, and they're not leaving their homes, and governors are making them stay there and isolate in place, okay? By the way, I can also say Oxford with this one because I reported it or found it independently. There was an outbreak of Legionnaires last October at Oxford main campus. And if you're interested, I can talk more about Legionnaires in another video. But that's a prime candidate. It was reported to have been weaponized by the Soviet Union between the years 1976 and 1986. But it causes respiratory system problems. It tends to only affect the elderly, and the effects are tied geographically to certain areas. So, it gives us an idea when you have a hot spot, it's something that could be responsible for that hot spot. So, and, obviously, as I've said in all my videos, none of these potentialities are mutually exclusive, okay? You can have the fraudulent data, okay? You can have the phony deaths on paper combined with ventilators being told to be used by people who should know better, okay? Combined with little bioweapon, activations, I guess, of sleeper cells in isolated situations. You can have all these things. So the scenario is, false flags require real deaths. Okay, that is the maxim. Okay, no one would say that nobody died at 9/11. Okay, that's the point. And I think the point with COVID-19 is turning out to be that they required X amount of deaths. Okay, how they got X amount of deaths is up to the captains of the field officers to make that happen. Okay, so that's why you see these different kinds of things. In one location, they had to tell the hospitals, like, oh my God, you better put everybody on a ventilator. And over here, they just had their yucky boys out there painting doorknobs, with some sort of an agent. So, if you're one of these handful, small, I can count on less than one hand the number of people who have told me that, their whole family got sick, right? Online, like everyone I know online, everyone I know in person, and all my clients and all my coworkers, that's several hundred people. And I've had like maybe 3 or 4 people tell me that their whole family got sick, I feel for you. I'm sorry. I wish that you weren't sick, but that happens all the time, I mean, I had probably more people tell me that their whole families got sick during the winter before COVID was supposedly here. Okay, and yes, they say that, well, COVID was just here then, but I mean, think about the winter before that and the winter before that. It just happens. Okay, and yes, when you're sick, you get emotional. I understand it. My wife is very, very sick, and I get emotional dealing with her. Okay, but when you get emotional, you stop being able to think rationally, and that's why science doesn't work on emotion. Okay, that's why scientific discoveries are not made by people who are in the heat of the moment. Okay, so if you got sick, this is what I'm saying. If your whole family got sick, this is what I'm saying. You have similar genetics, similar environment, similar diet, and similar habits, and there's no mystery why you have similar health outcomes. Okay, we don't need to think that there's some sort of a killer virus out there. But when you're in that situation, I mean, I was there too with all y'all. I had a cough, and I'm like, oh my God, am I gonna die? More to the point, is my wife gonna die? Am I gonna pass this to my wife because she's immunocompromised? I was there for a couple months until, the thing that did it for me, okay, going back in time, like people don't remember this, but the thing that did it for me was, first of all, they're saying, don't wear masks. Don't wear a mask. Masks don't do anything. And then all of a sudden they're saying, just cover your face. Just cover your face. Use a bandana. It doesn't matter. Just cover your face. Okay, that flip-flop just made absolutely no goddamn sense to me. Pardon my language. But that was when I stopped believing. Okay, and that was like, I don't know, April, May, sometime. Uh, so that's my update for today. Managed to keep it a little bit more brief than usually. Um, so I'm going to close by just saying that we are in some financial duress, my wife and I, as I'm sure so many other people are in this crazy mixed up world. So if anybody out there appreciates this information enough to make a small contribution to our plight, that would really be appreciated at this moment. And of course, that would help me put more videos out there, which I'm going to really try harder to do in the future. So at any rate, if you can't contribute monetarily, you can obviously still contribute by sharing this video and telling your friends about it, talking about it. I had a great time going around doing errands with my mask. Do I need this? Okay, I'll put it on. Do I not need it? Okay, good. Well, let's talk about why, we think masks are silly. I had some good conversations here in the suburbs of New Orleans about that stuff. And, that's the kind of model I think we should go for. Just talking to people, really just being real. Okay. So anyway, share this video, please. Tell your friends if they can subscribe. I could use some more subscribers to get that magic youtube.com/fdogfromair URL. Yeah, comment and do all the things. Yes. All right. This has been Evan Benton of Dogg from Air. Thank you, and be safe.